Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders.
Woohoo!
All right, I'm Justin Burt, joined tonight by Dr. Jessica Hain and our producer, Sydney Ingles. Say hi, Sydney.
Hello!
We are excited to have a great team tonight. Our guest, Dr. Rohan, takes a deep dive on common presentations of tinea infections and mimickers. But before we dive into content, hey, Jessica, can you remind us about the show?
Sure. We are the pediatric medicine podcast. We interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
We have a fantastic conversation today with our returning guest, Dr. Craig Rohan, who is a dermatologist and pediatrician at Wright State University in Dayton, Ohio, where he also holds a faculty appointment in the Department of Pharmacology and Toxicology. Prior to joining Wright State, Dr. Rohan retired from active duty following a distinguished 24-year career as a physician in the United States Air Force. He has been fortunate to have been awarded multiple teaching awards during his career, including Teacher of the Year, and was also awarded Clinician of the Year by Wright State Academy of Medicine in 2019. Personally, he enjoys biking to work, running, and watching the NHL Stanley Cup champion Colorado Avalanche. As a regular listener, Dr. Rohan is excited to have been invited to take part in another Cribsider podcast.
Dr. Rohan teaches us how to differentiate annular skin lesions in our patients, why his favorite topical antifungal is ketoconazole, and when to treat tinea versicolor with a combination of oral itraconazole and, quote, wallowing in sweat.
I'm so excited. Justin, I think you mentioned having a joke for us.
I do. Are we ready? So, Mushroom walks into a bar, orders a drink. Bartender says, "Hey man, we don't serve your kind here." Mushroom says, "Give me a chance. I'm a fun guy."
But
Fungus joke. Welcome back to the show, Dr. Craig Rohan. It's great to have you. Welcome back to the Cribsiders.
Yeah, thanks for having me. It's great to be back.
We're an informal group, as you remember. I hope it's still okay to go first name basis. Craig, is that okay?
Absolutely.
Excellent. We're all friends. You provided a wonderful episode on atopic dermatitis in the past, where I promised you I would start prescribing topical calcineurin inhibitors. I still have not gotten the chutzpah to do so yet, but I think now I am remotivated to take that pearl from our last episode and put it into practice. But for those people who didn't listen to the episode, or it's been a while, can you remind us a little bit about yourself and give us a kind of a one-liner description?
Sure. So, yeah, I guess I'll go as your prior guest has said. I'm a father, I'm a husband, I'm a physician scientist outside of medicine. I'm a big bicyclist, although I fell off my bike in August and had a nice little concussion, a couple of days in the hospital, but I'm better. And I like to snowboard. And I guess the update from last podcast I did, my favorite hockey team, the Colorado Avalanche, won the Stanley Cup last summer. And if there are any hockey fans who are listening, some might be annoyed because their team didn't win. If they're from Colorado, they'll probably be happy. So
this is great. The hockey, the snowboarding, and concussion, all of those things go together. This is
I suppose.
It's a good fit. I have not gotten into hockey. When the Las Vegas team was the underdog, that got me in. But the Golden Knights, is that right? The Vegas Golden Knights?
Yeah,
it's been a while.
Yeah. A lot of hockey fans don't like them because they were instantly great.
Yeah. There's
like no paying the dues. I had 21 years of watching my team between Stanley Cups, and they went to the finals the first year, but they haven't won the Vegas Golden Knights.
Yeah.
But it's all good.
All good. All right. Yeah.
Hockey fans like other hockey fans. So.
Well, this will be a good episode for the hockey fans.
One other one-liner, I should say, actually, so I actually have no conflicts of interest with topical calcineurin inhibitors. That you made it sound like I was selling them, and they're not like the panacea for atopic dermatitis. But a pediatrician should be comfortable using them, and they certainly are safer than topical steroids, other than that they sting. And pharmacy benefit managers tend to not like to approve them, even though they're generic and relatively inexpensive. But boy, it sure sounded like I was hawking some topical calcineurin inhibitors at that intro. So.
I apologize. I just vividly remember being like, when can a primary care provider prescribe this? And you're like, yes, a primary care provider can definitely prescribe these. So I'm still going to work on my comfort level as one small tool in my otherwise large bag of topical steroids.
Yeah,
toolbox.
no, it's all good. It's all good.
Thanks for clarifying, Craig. So I'd love to ask you one of my favorite questions, which is, what is a book that every physician should read?
Yeah, I'm probably showing my age, and I hope this isn't a cliche book, but I think it's 40 years ago, Oliver Sacks wrote The Man Who Mistook His Wife for a Hat. And again, actually, all the Oliver Sacks books are good, and even just the story of the guy is pretty interesting. And so obviously I'm a pediatric dermatologist. I'm not a neurologist, but the thought process of a physician, I think, is well outlined in those books. And so I think that's great. I would also say maybe just a page turner, any page turner. I think we spend so much time reading journals. I spend a lot of time on med Twitter, and it's probably not a bad thing to read something not medical too. So.
Agreed. That a great canonical medical text, The Man Who Mistook His Wife for a Hat. And I'll share with my pick of the week a book that has stuck with me, Cloud Cuckoo Land. Have any of you seen it?
It's on my to-read list.
It is also on my to-read list.
If this can be the impetus, it is the topical calcineurin inhibitors of modern fiction. It's it was amazing. It was really good. So I'm spreading the gospel of Cloud Cuckoo Land.
That's awesome.
This is great. Let's dive into some content. We have an ambitious script that I'm excited about.
But before we do that, let's hear from one of the sponsors that help support the show. Our episode today is sponsored by Panacea Financial, a nationwide digital bank built for doctors by doctors. Whether you're a fourth-year med student, a resident, or an attending physician, Panacea Financial is a bank designed specifically for you. Panacea offers free checking with no ATM fees nationwide, 24/7 customer service, and loan options custom-made for physicians or trainees at every career stage. Instead of running up credit card debt, try their PRN personal loan that is designed to give you a better way to cover expenses such as relocation, board exams, home renovations, or even consolidating high-interest debt. Panacea's PRN personal loan is funded in as little as 24 hours, with interest rates starting at half of a typical credit card. They understand money can be tight, which is why they offer a period of no or reduced payments on their PRN personal loan. They also support physicians in other ways, including helping you start, expand, or even buying into a practice or surgery center. If you're ready to join the thousands of doctors who have declared independence from traditional banks, visit panaceafinancial.com today to open your free account. Panacea Financial is a division of Primus member FDIC.
Sydney, do you want to lead us into our first patient?
Yeah, absolutely. So we have a couple of cases today. We're going to start with our first case. You are seeing Tanya, a 14-year-old girl with no significant medical history, in clinic for concerns of a rash. About a month ago, her caregiver noticed a round patch right beneath her axilla. Over the past month, it has gotten slightly bigger and causes moderate itching. On exam, Tanya is a well-appearing child with medium dark skin. Under her right axilla, you see an approximately 3-centimeter erythematous round plaque with raised edges and central clearing. So I think probably for many of us who see kids in clinic, this is not a particularly surprising presentation, but I would like to ask you what initially stands out to you about the case?
Well, from the case presentation that you had given, and it's good that it's not so classic that we have nothing to talk about, right? In many cases, and we'll think of annular lesions, meaning basically circular lesions having kind of a specific differential, and that differential can go from inflammatory to infectious. There's some reactive processes, and so then when we're actually seeing a patient, we look for things like you mentioned, central clearing. We ask about symptoms, and so the case as written actually has some nuance that would argue for and against various conditions. So, for instance, Tinea corporis, so a fungal infection of the skin caused by dermatophytes, it tends to be relatively asymptomatic. We see that, for instance, actually harkening back to kids with atopic dermatitis, we'll see Tinea corporis far more often in kids with eczema because their barrier function isn't outstanding. There may actually be some reasons why their immune system might be slow to fight off dermatophyte infection as well. But in many cases, if you have a kid with a lot of eczema and then one surreptitious little Tinea corporis lesion in there, the Tinea corporis is going to be less itchy than their eczema. So that's a relative, clue. On the other hand, if they have a solitary lesion or just a couple of small tinea corporis lesions, sure, that they absolutely may find some irritation with it compared to their baseline skin. And then, of course, the buzzword of central clearing, right? So that is to say that the edge of this annular plaque is kind of advanced or heaped up a little bit scalier. And then in the center, there's been sort of some recovery or maybe even some complete healing of the skin, so to speak. We typically see and think of with tinea, but, other annular conditions, specifically granulome annulare, which is really not rare in kids. We see it in kids, not infrequently at all. It'll also have central clearing, sometimes actually more impressive central clearing than tinea corporis would. So again, the case is great. And you have to think about it a little bit, and that's great. That's why we're here.
And when I see a case like this, I typically think this looks like tinea or ringworm. The parent always says, like, does my kid have a ringworm? But I try to think about nummular eczema. I try to think about granuloma annulare. Are there other data points that you're looking to see? I feel like if I'm worried about tinea corporis, I start looking for tinea capitis. I start asking about a history of eczema. And I guess, what are other data points that help you guide towards one diagnosis?
Yeah, for sure. So again, comorbidities that put them at risk for tinea are important. And then actually some kind of environmental triggers, including pets. So we love our pets, but pets are not an uncommon source of tinea. Many of our species of dermatophytes, have the name Canis within the genus or species and so forth. So it's not uncommon, and especially the more exuberant cases of tinea. So for instance, probably the two most impressive phenotypes of fungal infections of the skin are, as you mentioned, tinea capitis, so ringworm of the scalp, where there can be a loss of hair, which unfortunately can be permanent if it's not detected. And a subset of that is the dreaded carry-on, which essentially is where you have a tinea capitis fungal infection, but you have kind of the double misfortune of developing a type 4 hypersensitivity to the dermatophyte. So you're both infected by this fungus, but you're actually in fact allergic to it. And that allergy causes a big part of that carrion presentation. It's boggy. You get what we call spongiotic vesiculation, which is sort of the same reaction under the microscope that you see with, poison ivy, because again, you're actually not just infected by this dermatophyte on the scalp, but you're actually allergic to it as well, which is sort of a, cruel joke. And then the second kind of impressive presentation is that the further you get away from so-called human dermatophyte species to plant dermatophyte species, or even to soil, what we call saprophytic fungi, the more exuberant the reaction is going to be. And so in the most extreme cases, we have what we call bullous or vesicular tinea. There's a couple different species that can cause that. Most commonly, Trichophyton montagravenes or Trichophyton tonsrans. Those two species are, you can kind of pretend like you're a little smarter than you are when you see what looks like bullous changes within a plaque of ringworm, and you send a fungal culture and you kind of tell your resident or med student or the parent that it's probably one of these two species that potentially has implications in the dosing of the treatment. So again, there's a broad range. Before we even talk about mimickers, before we talk about granulome annulare, tinea can be its own kind of interesting condition. So.
I'm curious, you mentioned sending a fungal culture. I think often we think of this as a clinical diagnosis. What are sort of the situations where you would think about doing further testing, looking with a Woods lamp, something like that?
Yeah, no, I got to tell you, I think dermatologists, maybe the further we get out from residency, from med school, the more we send cultures. And that's probably increased in the past, maybe 3-4 years since susceptibilities have become available. So, years ago, it was quite the fancy thing to actually get susceptibilities on a fungal culture. Now it's really not a big deal. And that can matter for either medically complex patients. So it's uncommon that we're going to have a little kid who is on something for which P450 interactions are going to be a problem. But they're out there. I mean, they're out there. They're on meds. They're on meds we've barely heard of. They're on meds from, multiple specialties at the same time. And so sometimes having susceptibilities actually really helps with finding an option that's going to work if you have limits. And then tinea is the great devil, the great enemy. I could show pictures. I have many pictures of cases that shocked me that they were tinea, and that's partly because it's so easy. The barrier of entry for topical steroids, which will change the presentation. We call it tinea incognito, which is to say that even using a lot of over-the-counter hydrocortisone, which has a bunch of brand names that we won't give, but basically over-the-counter strength hydrocortisone, or going to whoever, urgent care, ER, pediatrician, another dermatologist, whatever, nobody gets off here, and having gotten empiric topical steroids, which were used on something that actually happened to be a fungal infection of the skin, and it changes the whole architecture and can absolutely trick the best of us. So no, my threshold for doing KOH, or usually we actually use something called chlorazole black E, which is kind of a next generation potassium hydroxide KOH, and that's just a little bit easier to see the fungal elements. Unfortunately, it's flammable depending on your health situation. If you're in a hospital, you're probably going to have to keep it in like a locked safe. If you're outpatient, you probably get away with murder. But there's some implications with that. As we all know with KOH, actually, you flame it. Back in the day, and I graduated med school in 2001, you could find coworkers who smoked. In 2023, there really aren't too many smokers among your medical staff, hopefully. So you're literally trying to find a lighter or something. So anyway, doing a stain in the office, we do that often. But even if you don't have a microscope, even if you don't have a CLIA binder and you have tests that you take every year to prove that you're qualified to do it, then a culture is simple. And you can do a culture with a sterile urine cup. You can do a culture with most culture swabs. So what you would use for a bacterial culture, most microbiology labs will accept for a fungal culture. So to actually get a fungal culture is no big deal. I do it often when I have med students or residents with me. Sometimes they're like, you wouldn't do that culture if I was here. And I was like, of course I would do that culture. Again, some of that is selection bias, but I do think that, it shouldn't be felt that that's some, grandiose test left for the experts. In fact, it can really get a head start on your patient getting better, especially, again, for medically complex patients or for patients who, have tinea capitis, where there's a concern for scarring and alopecia. So.
I do want to say that with dermatology, I feel like a picture is worth 1,000 words, and it's interesting to do an audio-only presentation when we're talking about dermatology.
Of course.
But
Yep.
recognizing that maybe many of our listeners feel comfortable recognizing classical appearance of tinea corporis, but maybe not some of these atypical, what happens when someone's already put a steroid on it. Do you have images that you could share that we could put in the show notes?
Yeah, I think we can find some. I'll work on that. So yeah, in general, you'll see polycyclic presentations, so kind of a clover type appearance, which is sort of, kind of an edge of the tinea was able to grow from, one corner of that ring. And then you can have, multifocal areas where multiple areas of the body are infected. We don't see it so much in kids, but in adults, we'll see, one big advancing, 3 foot wide annular plaque. It might start like in the right chest and go along the flank and down the groin and to the right thigh and the left thigh to one butt cheek and up to the back. That turns out to be literally all of it was, tinea. Again, in kids, their immune systems generally are kind of a little bit better than that. They're able to kind of fight things off, but yeah.
And maybe while we're talking about different presentations and different images, one of the big movements I know in medical education is getting a better understanding of different skin tones and how different clinical presentations are different in different skin tones. Can you talk a little bit about that? Is tinea one that might present differently based on tone of skin?
Yeah, well, so there are a couple issues. Obviously, the appearance of it can appear different between patients of various Fitzpatrick phototypes or various complexions. But actually, the greater premise is a step before that, which is to say that we see great, differences in susceptibility to fungal infections among various ethnicities. So African Americans have much higher rates of tinea capitis. It's not socioeconomic. nobody's doing anything wrong. It really doesn't reflect differences in grooming practices, even acknowledging that African Americans typically wash their hair, far less frequently because of dryness than, for instance, a lot of Caucasians or other ethnicities would. And so and there actually is some interesting science that I think is kind of like, I guess it hasn't captured interest beyond kind of the extremes. So for instance, when I see the extremes, even though it's not a superficial fungal infection, we know, for instance, that patients of Filipino descent have much higher risks of serious complications for coccidiomycosis, right? So the genetics of that have not been entirely determined, but for years, my subspecialty clinic was shared with infectious disease. And if we had a patient with coccidiomycosis that can have skin presentations, they would essentially be on lifelong azoles just for being of Filipino descent. And then, part of the reason we think actually African Americans have a higher rate of Tinea capitis, hopefully not, again, life-threatening extreme cases such as coccidiomycosis we see with patients of Filipino descent, but actually some of the underlying science we believe, and this always sounds a little like you're going off the tracks here, but some of it is probably related to positive blood type. Rh positive blood type probably confers some small increased risk of fungal infection. Again, there are all sorts of bogus things related to supposed blood types that, you can kind of start doing astrology with blood types and find books and all these things that are in no way accurate. But there does seem to be at least some epidemiologic link between having a Rh positive blood type and having a higher propensity to having, for instance, Tinea capitis in particular.
Wow.
So, and then that continues where, again, our African American patients not only have kind of an increased susceptibility, but that increased susceptibility probably puts them at increased risk again for carry-on. That is the kind of more exuberant, boggy presentation of Tinea capitis, because the mechanism behind, that complication is likely related to having caught, Tinea capitis more than once, where again, it became sort of a sensitizing event that kind of the second time around or later in the initial presentation of Tinea capitis, you now develop this kind of comorbid type 4 hypersensitivity reaction where, again, now you have all those changes, which can, significantly increase the risk of scarring. So yeah, massive implications for this condition, how it appears, and then of course, social determinants of health in terms of, are patients of color able to get seen in a timely fashion? Are they diagnosed, as early as they could be? Are they referred for specialty care if they need it? And then, gosh, if I write a prescription that's going to work, are they going to get it filled? Is it going to be filled by their insurance company? Are they going to get some pushback for it? And so, it goes from every aspect of this care. So for sure.
No, thank you. Appreciate that. I think it's an important part of dermatology and something we try to bring up in every conversation and episode to acknowledge health disparities, address them, and provide some education for us and our listeners. As far as, going on to access treatment, we love talking about treatment because we're problem solvers here on the show. Let's talk about treatment, presuming that we feel pretty confident Tinea corporis, and right now we see no evidence for Tinea capitis. What's your go-to antifungal? Is there a reason to pick one subclass? What's kind of the first thing you reach for? And how do you counsel a parent or patient on treatment for Tinea?
Yeah, absolutely. So talking about, topicals first. So it is always important to remember that Tinea, by definition, is essentially a dermatophyte condition. So that's not yeast. And that's what's important to remember then is that things like nystatin are actually not going to be effective for it. So they're very effective for yeasts. They're very effective for Candida, Malassezia, a few of the yeast species that can cause things like diaper rash, diaper candidiasis with satellite lesions. They can cause, thrush, a number of fungal infections of the skin. And those can be treated again with medicines like that. But for actual Tinea epidermophyte infections, unfortunately, that class of medicine, nystatin, is not going to be effective. And unfortunately, it can delay. It can, now, unfortunately, things are advancing, get second lesions. Families are being diligent. They're doing exactly what they're supposed to do, but it's the wrong med. So in terms of treatments we typically use, the azoles, in particular, ketoconazole, is probably the first line for a few reasons. As a topical, it's cheap, It is generic. The actual mechanism of azole antifungals, basically, it's akin to beta-lactam antibiotics, where you're basically punching holes in the cell wall of fungi. That's a good, fungicidal type of mechanism, and so we use it often. Ketoconazole actually has a little bit of 5-lipoxygenase activity. So if you go to like your grocery store or to a drugstore, you'll see ketoconazole shampoo on sale, and it's actually for psoriasis. It's not for a fungal infection, and that's because, again, ketoconazole in particular has a little bit of 5-lipoxygenase activity, meaning it has a little bit of an anti-inflammatory mechanism separate from poking holes in the walls of epidermophytes. So, and actually most other azoles have far less anti-inflammatory activity than ketoconazole has. That's why it's kind of an old standby, old favorite. Other azoles are fine. Again, new proprietary ones. In many cases, the difference actually has to do with kind of the size of the molecule and the stability of the molecule, that an application sort of lasts longer and thus is more effective. Sometimes that can translate to hundreds and hundreds of dollars for some proprietary name brand. And then that you can kind of read from my tone, in most cases probably not worth it, right? So. And then, so terbinafine, you can get over-the-counter topical terbinafine, and it is another relatively good option. The problem with terbinafine is it does actually have holes in its spectrum. So I know Dr. Hain, for instance, is a hospitalist in this crowd. And so if you've ever had a kiddo who unfortunately had an invasive fungal infection and they had like fungal sepsis, we don't reach for IV terbinafine. I actually don't think it exists. And that's because, it actually has holes in its spectrum. So believe it or not, actually Candida is very resistant to terbinafine intrinsically. So terbinafine is fine, and it's a reasonable option, but it does have a few holes in its spectrum that the azoles don't. And then there's we tend not to use these in kids because kids' immune systems, again, we can only make so many assumptions, but in general, kids' immune systems tend to help us enough that we don't have to use things like, for instance, gentian violet, which is a classic treatment for elderly diabetics with difficult to clear fungal toe web space infections that can actually become secondarily infected with Pseudomonas, can be part of what leads to diabetic foot ulcers and amputations, and even worse. Again, in most cases, even kids with immunodeficiencies aren't going to require things like that. That's kind of a scorched earth that keeps it stained for weeks and weeks, can actually unfortunately have some secondary irritation. And then, of course, just for historical sake and kind of humorous, although it's not humorous. Back in the day, and I mean up until like the 70s and 80s, Tinea corporis and Tinea capitis was often treated with in-office radiation. So they would turn on their X-ray machine and give whatever some portion of a gray to treat some fungal infection. And so now I get to I take care of lots of kids, but I do see some adults, and I get to take care of skin cancers in patients who decades ago had radiation treatment for a fungal infection that was woefully inappropriate. So, but it was easy. It required very little compliance with treatment.
And if a family member asks, is this contagious, do you do any other counseling in addition to topical treatment?
Yeah, it is. It actually is contagious for sure. In fact, comes down to, some of the Rh positive blood type stuff I was talking about. Some of that comes from epidemiologic studies where, again, the positive blood types in a daycare or in a home, family members, mixed families of different parents and so forth. That's where it comes from. And again, that's where we talk about, potentially fomites. Fomites can include pets. So, not that every kid with tinea needs to have their pets taken to the veterinarian, but fomites can absolutely be a pattern. And then family members can be fomites. So if we have kids who are just impossible to clear, sometimes we do talk about treating close contacts. That's not usually from day one, but again, especially trichophyte and tonsorians, which is a common cause, Microsporum canis, that are two that we know are just perfectly happy to kind of have a carriage state that family members may actually be kind of reinfecting the patient who is unfortunately having a little higher susceptibility than those who are more of the carriers.
And is there a risk for resistance with these topical medications? I guess I think about like the people who are self-medicating with it. Is it a concern if people are just saying, the minute I start to see it come back, I'm going to start applying it again?
Yeah, not so much. The biggest issue with it is that, some, especially the over the counter strength options may not be as potent as the prescription options. The other issue is when we write the prescriptions, my SIG is always use it until 2 to 3 weeks after clearance. And then if there's even a hint of recurrence, then do it again for, a few weeks after you're sure it's gone. But in terms of resistance, yeah, again, I talked about how we can do cultures and susceptibilities, and that actually is no longer like some, crazy test to do anymore. And most of the time, it's actually more of an inherent resistance to certain species of epidermophyte that are part of that have that resistance. So not quite so judgy as we get to be with our poor stewardship of antibiotics. This tends to be more it was a bad choice because of that particular species and the option you chose first or whatever. So.
Well, you gave us a really great overview of topical antifungals and treatments that that we've used in the past that maybe aren't recommended anymore. But I'd love to hear a little bit more about, a case where you may have someone with really extensive disease, or perhaps they have Tinea capitis. Can you tell us a little bit about when you would use oral antifungals in your pediatric patients?
Yeah, no, absolutely. It's one of those things where you usually don't need to, but then once you need to, you need to, if that's said correctly. So hair-bearing areas tend not to have very good penetration with topical antifungals. That same applies for nails. Although in kids, we have some, I know we're talking about, kind of ringworm and tinea, but for our onychomycosis, families that are very diligent with using cycloperox and some of the lacquer type antifungals, they actually really can be very effective. In fact, the data in kids is pretty good when used, kind of correctly. But as for oral options, yeah, we typically have a low threshold to start them if patients have involvement over hair-bearing areas, or they have large areas, or like I said, if they have glitches, anything that's going to be a problem with getting treatment to the area, if they've got some comorbidities, which might actually include bad atopic dermatitis. So in terms of empiric initial choices, we talked about how topical ketoconazole of the various options tends to be first. Well, unfortunately, the azoles are generally quite safe, but can cause idiosyncratic liver failure. It's fortunately very rare. We certainly, think about it and have that concern. It's far more common in oral ketoconazole. So systemic oral ketoconazole really isn't a thing anymore. It's one of those things, I think you actually have to call the CDC for compassionate use. If you write a prescription for oral ketoconazole, your pharmacist is going to think you're an idiot and probably wonder what else you're doing wrong. And so it's essentially, out of there. So in terms of options, we use oral fluconazole, oral itraconazole. Those tend to be probably the two first line that generally safe in kids. Again, there are P450 interactions. And again, that's sort of different in terms of causing liver issues than kind of the rare idiosyncratic more severe fulminant disease that can occur. Again, very rare, fortunately, but it can happen. Again, the other issue is, again, obviously P450 interactions, which in most cases, again, a lot of complicated kids out there. We got kids on Coumadin. We got kids on, medications that are don't have quite the therapeutic indices that we'd like, that we have to think about interactions. And so sometimes if we can't use azoles, time-honored griseofulvin is an option. We tend not to use it nearly as often. It unfortunately has a lot more in the way of side effects. It's relatively photosensitizing. That actually does include in our patients of color. So you could have a Fitzpatrick phototype 6 African-American patient. That means incredibly dark complected. If you think of someone, in Africa, that complexion, that's kind of Fitzpatrick phototype 6. And if you give someone griseofulvin, even with that dark complexion, you don't warn them to wear hats, shades, sunscreen, you can give them their first sunburn of their life with griseofulvin. It can cause some headaches. It can cause some other side effects. But, it's something we'll use probably more often in adults is when I might write a prescription a couple times a year. And it's usually for a medically complex adult whose drug interactions prevent me from, they kind of corner me into using griseofulvin. Classically, when I was a young pediatrician, so I practiced in pediatrics for 4 years after my peds residency before I went back and did derm. And for decades, Grisea fulvin had been kind of the nice empiric option because it's kind of in and out pretty quickly. So Grisea fulvin had been something a pediatrician might use for a week or two while they're waiting for a culture to come back. And that's reasonable, but again, because of the side effects and even with my doom and gloom proclamations about rare complications with azoles, they really do tend to be safe. So they've probably replaced Grisea fulvin as kind of an empiric option. You actually sometimes have a hard time finding Grisea fulvin. And then terbinafine, oral terbinafine, certainly an option. We use it usually first line for onychomycosis, but that has a lot more to do with the pharmacokinetics of the medication in the nails and in the skin, and that if you give, for instance, 6 weeks of terbinafine, oral terbinafine, it's going to last and have kind of a fungicidal effect, for a few months. And that's really the benefit of it. You can do what we call pulsed azole therapy. So again, back to fluconazole and itraconazole. It can be given. So for instance, 1 week, a lot of times we'll do like maybe 1 or 2 weeks to start daily use for 1 or 2 weeks, and then might take a couple week break and then do 1 week a month for a few months. And again, the pharmacokinetics of azoles and the way they kind of sit in the skin and last in the skin allows you to do that. So if you were to give, for instance, one week a month for 4 months, you're basically getting, 4 or 5 months worth of antifungal effect. If instead you gave those 4 weeks in a row all at once, you're getting, kind of 2 months, maybe 1 month and 3 weeks worth of effect. So we do a lot of pulsed azole therapy. Again, unfortunately, you can imagine then becomes compliance, understanding. You got to make sure that the way you describe it to the patient is explained. What you write on your SIG actually gets transcribed by the pharmacist. We usually get like 140 characters, a bit like Twitter. And sometimes the pharmacists, unfortunately, kind of freelance a little bit and they'll, shorten it. So if we have a long, 139 well-crafted character SIG, sometimes, especially for topicals, this, I guess, is a side rant, all of this long diatribe of what they're supposed to do. And when the patient brings their tube in the next visit, it says apply twice daily. And it's like, that's not what I said, but anyway.
When you start a patient on the orals for Tinea capitis, 2 rapid fire questions. 1, lab monitoring. Is that out the door now? We don't have to worry about that. And 2, do you do like an adjunctive shampoo as well or no?
Sure. So actually, let's do the adjunctive shampoos first. So I think that makes a lot of sense. I do a lot of salicylic acid shampoo. 3% is often covered by Medicaid plans, at least in Ohio, where I practice. And then I'll alternate that with topical antifungal. So the salicylic acid is going to kind of descale. It's going to let the topicals, the shampoos, work a little bit better. And so, I might give a ketoconazole shampoo. You're getting a little bit of antifungicidal effect, but remember, you're also getting some anti-inflammatory effect, which is probably what I'm really after. When the azoles that are, again, in the case of Tinea capitis, when those antifungals are getting through the system and kind of destroying the cell wall of fungi, there is some irritation. There is some irritation that occurs. That's sort of a good thing that's happening. But it's not a bad thing to add an anti-inflammatory agent like salicylic acid or ketoconazole. So depending on how often a patient is washing their hair, again, that varies quite a bit by hairstyle, ethnicity, and so forth. I might have them alternate salicylic acid shampoo one night with ketoconazole the next night. Again, the take home on that is that by itself is not adequate. You definitely need more than a topical or a shampoo for Tinea capitis. But it's a great adjunct. So.
And lab monitoring, do I have to order LFTs anymore?
Sure. So again, there's always a question of risk tolerance. Azoles are actually really, as I said, I started out with, rare cases of fulminant hepatic failure. So, I actually do skin checks on a patient who I believe in her 20s developed fulminant hepatic failure and needed a liver transplant. So I see her for her routine skin checks because she unfortunately has an elevated risk of skin cancer because we're now immunosuppressing her, of course, because of her elevated lifetime risk of malignancy. Now, this is an anecdote that never happens. It's fortunately very rare. And I don't want the anecdote of, my patient I see every year and always makes you say, gosh, how much do I want to, check labs on these? The truth is, unfortunately, the most serious complications, you're not going to have excellent lab monitoring as a way of sort of detecting it early. You're not going to have this window of intervention that lab monitoring is going to work well in many cases of, fulminant hepatic failure. It's the model of you ate a mushroom you weren't supposed to eat, and now your liver basically starts digesting itself, and so lab monitoring along the way is of there's relatively low yield. That said, classically for back when we do Grisea fulv, and after about 6 weeks we would typically do lab monitoring, and then certainly in adults still. When we treat onychomycosis, we'll do lab monitoring if we're using terbinafine. And so if a patient is on it for months and months, well, you could say clearly they're doing fine. They've been on it for months and months, but it's probably not an unreasonable thing to check labs. Again, especially if they're on medication that's also hepatically metabolized, if there was a low interaction risk. Or, sometimes I'll see a 4 or 5 year old, at least in Ohio, we typically will check a CBC and sometimes a lead depending on zip code and so forth. And it's not the worst thing to add on transaminases. So anyway, in terms of what is mandatory, there's plenty of support for not following labs, especially if you're able to get in and get out. That's why we often will do the pulse therapy. But if someone is medically complex, if someone's going to be on it for a prolonged period of time, it's certainly very reasonable to consider doing lab monitoring.
So we've talked a little bit about the treatment management when we are pretty confident that it is a Tinea corporis diagnosis. Can we go back and talk a little bit about some of the mimickers? And on my perspective, I would love to hear more about granuloma annulare because I just do not feel confident at all in that diagnosis.
Yeah, no, sounds good. So again, that's one of the big mimickers. In fact, I'll say that a lot of times when I'm seeing a new patient with kind of slam dunk granuloma annulare, and for instance, slam dunk would mean that there's really no epidermal change. And what I mean by that is if you rubbed kind of your finger, maybe gloved, maybe not gloved, over tinea, it's going to feel rough, somewhat sandpapery. Probably even the quote unquote central clearing areas is probably not going to be normal. It's also going to be just at least slightly scaly. The pigmentation may be off. It'll certainly be spared from, kind of that leading edge. On the other hand, granuloma annulare, it's going to have basically it's an expansion of dermal cells. You basically have macrophages in the dermis that have kind of engulfed a little collagen and reproduced almost a scar-like response under the skin. But the very top surface of the skin is going to be smooth. There's going to be a bump undulation as if you had stuck a BB under the skin and shoved it through the skin to a point where you couldn't tell that you had made a little cut to get it under there. But the actual surface overlying the skin of granuloma annulare will be smooth, even though there's an undulating surface. And so, again, it'll often be it'll be a prettier ring than ringworm will be. And so granuloma annulare is kind of an interesting diagnosis. It's, there's some interesting science in that it probably has something to do with IGF-1 receptors on the macrophages that, and when we think that because adult patients with diabetes get it, sometimes they'll get it over large portions of their body. Although we'll also see patients who don't have diabetes who can have severe cases of it as well. We also see it in pregnant women. It'll often go away without treatment, weeks after delivery. So that, again, lots of growth factors binding up to these IGF-1 receptors on the macrophages. The macrophages, do as they're told when their growth factors are activated. And so, we'll see it at various ages in kids. And it often follows what we call a Kebnerization pattern. That's a word we think of with psoriasis. It basically is why you get psoriasis over your elbow and knees. And that is, you sit with your elbow on the table, your jeans kind of tent over your knees. So there's friction, there's relative friction and trauma over your elbows and knees. And so that's where psoriasis likes to go. It's similar with granuloma annulare. The back of the wrists, areas that are the shins. You bonk your shin, and a couple weeks later, you notice granuloma annulare. Actually, kind of the hinges of the body. over the elbows, in the armpits. Actually, back to the case, the fact that it was behind the armpits, that's a place that granuloma annulare loves, for instance. So those are some of the features. And again, you try to get it right. That's why a culture is useful. But if there's nothing to scrape, boy, that's a pretty good sign that it's granuloma annulare. So again, back to that BB under the skin analogy. If you're actually getting flakes to send for a culture, yeah, tinea is a good thought. It might be that. You might consider giving a topical azole while you're waiting for the culture to come back. But if sending a culture would entail, blood, then you very well may have granuloma annulare, and empiric treatment with the topical steroid may be very reasonable. And it tends to be, once you have the diagnosis, we tend to use medium and relatively high strength topical steroids. Again, we have a lot of respect for steroids in kids. I think more so than Dr. Burke. He said he's going to put it on everything. But anyway, for all the volume to body surface area considerations of kids, we try to dole out steroids only when we need them. But for granuloma annulare, because we're trying to chase away macrophages that are a couple millimeters under the skin, we tend to reach for a little bit stronger steroids. For more severe cases, so for instance, if you had a kiddo with granuloma on their face, which can happen, there's no FDA-approved treatments, but actually hydroxychloroquine can be effective for it. It's one of the time-honored validated uses for it. And then, we'll say like an older kid who could tolerate it, at least in dermatology, we'll use intralesional steroids. That needs to be kind of done right with caution, so you don't give them a dent, give them a scar from it. But and then for adults, we use all sorts of crazy stuff. We do a lot of ultraviolet phototherapy. Actually, we'll use that for teenagers too in a tough case, but basically there's certain wavelengths of light that chase white blood cells out of the skin, and we're able to kind of give specific doses that don't mutate DNA. And we use that for a lot of conditions, and granuloma annulare is one of them. So,
I remember when I was a resident, I did a pediatric dermatology rotation, and we saw granuloma annulare twice, and it was both referred by the primary care doctor for treatment-resistant tinea. Yep. And so I always think of those as like the mimickers of if what you're expecting doesn't work. And to my defense of putting the steroids on everyone, absolutely. I just want to share with our listeners my algorithm, as I mentioned to you, is putting a steroid, taking a photo, steroids for 2 weeks, bring them back. If worse, antifungal for 2 weeks, bring them back. If that doesn't work, dermatology referral. And I've never gotten the diagnosis wrong with that. Because
there you go.
The dermatologist usually cleans up my mess if I do anything wrong.
Well, there's some obscure ones that so subcutaneous lupus is very annular. It could look like a ringworm. So that one might take a little longer to get better, but that's fair. I was going to say, in terms of kind of a pearl in this realm, what I'll sometimes do if I really am having to hedge is I'll do a few weeks of a topical azole, for instance, ketoconazole. And that very same day, I may send them with a script for a mid-potency topical steroid. Triamcinolone actually, is kind of a time-honored, kind of a big gun for kids, but relatively safe. And I'll tell them they can go ahead and use the ketoconazole, twice a day for say 2-3 weeks, and then after that period of time, they can add the topical antifungal where they're doing both together. Now, there are combined products that have, for instance, clotrimazole and betamethasone. There's some other combined products. Most dermatologists, most of us don't love those because the match isn't great. So, for instance, betamethasone is a very strong steroid. It's fluorinated. If you want to thin the skin, that's like a great one to use. So usually that's not a goal. That's a complication, right? So we tend not to like those combined products, but again, if you're doing a few weeks of topical azole, I mentioned that it has some anti-inflammatory properties. So, you can sleep well at night, that you are actually helping the patient regardless. And then when a culture comes back, or even just empirically adding a topical steroid after it's had a few weeks for the azole to have its effect and use them together is a very reasonable approach. I would call that good care. If it doesn't get better, absolutely send them my way. I'll be happy to see them. And then I'll consider some of the more obscure things, because at that point, they've gotten great care. especially if you've had gotten a culture along the way and you had that approach and they're not getting better. Boy, that's someone will be really happy to see.
I always felt the combination products were just intellectually cheating, like
Yeah. No, internationally, again, I did my residency in Los Angeles, and we would have patients on, Quadraderm, which is an ultra potent topical steroid, an antifungal, an antibacterial, an anti-inflammatory. Again, it's actually, if my job could be replaced by like a quadruple strength topical, that'd actually be really great for people with like vasculitis and syphilis and lupus and some of the other serious things I take. I guess I would go find some other job, but unfortunately, the combo doesn't quite work all that well. And a lot of times, though, as much as they're helping, they're hurting. So
we will try to avoid those. Earlier in the episode, you mentioned a couple other things on your differential. I think you mentioned nummular eczema, psoriasis. I just want to make sure we touch on some of the other common mimickers that you think about when you're thinking about Tinea corporis.
Yeah. Well, so psoriasis is rare, but it's not that rare in kids. There's a big flip between kids and adults in that, we see a lot of eczema in kids. We don't see much psoriasis. And then kind of in the second, third decade of life, so late teens, that actually will switch where we stop seeing as much eczema in adults. We see a heck of a lot of psoriasis where there's kind of this flip. And so a solitary psoriatic plaque, you can get your first, bad luck of having psoriasis, which has a lot of genetic HLA risk factors. There are some meds that can cause it. We typically don't give those to kids. But anyway, there's a lot of factors why psoriasis can occur. But you can absolutely have a pattern where you get like one annular Tinea corporis looking plaque that turns out to be psoriasis. And that's rare, but it's not that rare. And again, that it typically won't have central sparing. It'll be ridiculously scaly, right? So the patients will tell you, like, if it happens to be like a teenager and they shave, it'll scale back up like the same day. That actually gets back to the pathophysiology of psoriasis, where obviously we can have all sorts of autoimmune conditions in the skin. You can have swelling between the cells, that's eczema. You can have, degranulation of mast cells and eosinophils, that's hives. You can have, destruction of hair follicles, that's alopecia areata. But actually the autoimmune activity that happens with psoriasis, the keratinocytes basically start growing in uncontrolled, unregulated fashion. So it's not cancerous, but their differentiation becomes very poor, and they basically grow about a month's worth of keratin every day. And again, so psoriasis will be far scalier than tinea, as kind of a general appearance. Nummular eczema will be incredibly itchy. It will be just unbelievably itchy and relatively treatment resistant. So especially to like over-the-counter topical steroids or low-potency topical steroids, it often just won't even touch it. So response to empiric therapies before you admit the patient might be a hint that you're dealing with nummular eczema. They may have some of those, so-called Hanifin criteria, which are the minor diagnostic criteria that help us decide someone might have eczema. Things like the Denny Morgan fold pleats under their skin and hyperlinear palms and all sorts of fun things that I can see a patient who doesn't happen to have eczema. I catch them on a good day and they have eczema, but they didn't have eczema that day. And we can go and look for a few of these and have a pretty good probability that, yes, they actually did have eczema and we're going to start these treatments. And then, one other, I guess, mimicker, but kind of actually within Tinea would be, Tinea versicolor, which is actually a yeast form. So it's not a dermatophyte. We typically do treat it with azoles, and it's got more of a polycyclic, small little circles. They're thin. They scale very little. It's hard to call them really ringworm, and they don't really centrally clear. But you can use topical ketoconazole. You can use topical shampoos, including selenium sulfide. That one's a little less favored in my own personal preference, in that the mechanism of selenium sulfide is basically to make yeast slippery. That's kind of a stupid mechanism of action. I like things that poke holes in cell walls more than things that make things slippery. That's just not how we roll, but it can be done. But for more widespread Tinea versicolor, we'll often do, and again, if you've seen this before, you know where I'm going with this, but if you haven't, it's going to sound like I'm kind of crazy in that what we'll do is we'll give 2 to 4 pills, like the total prescription, and we'll have the patient, often we'll use itraconazole or fluconazole, but we'll have the patient take, maybe 100 to 200, maybe higher, depending on severity and their size. And then they'll basically exercise. They'll exercise, they'll build up a sweat. And then we, actually based on the faces of my hosts, I guess they've never heard this. So they basically, they build up a sweat, and then we actually want them to wallow in their sweat for about 6 to 8 hours. At this point, the parents are like, "Are you crazy? Did we? I wanted JD or Turk, and I got the janitor, I guess, But anyway,
What a reference!
And so what happens is you're actually excreting the azole up through the pilosebaceous unit into the follicle, and that's actually far more effective than applying it topically or just taking it. By actually sweating the medication out about an hour after you take it when peak concentration is high, it works well. And then you take a shower because you probably smelled bad. And then you do that a week or two later. So you could argue there's maybe some benefit that you're getting a teenager to work out. You're having the parents tell your teenager to work out. The wall and the sweat part's a little annoying. But this is the time-honored way of treating tinea versicolor, especially when it's widespread. It can wrap up onto the cheeks and neck, and it can be, it can end up occupying, 15, 20% of a teenager's body surface area, where their complexion actually looks different after treatment. So
that is a great pearl. I feel like I would have remembered that from med school. I don't think I'm not sure if I've been taught that. That's great.
Yeah, I promise I didn't make that up. It's kind of time honored. And then again, back to genetic differences. Some people are prone to it, and it's probably not a bad idea to use, for instance, a ketoconazole shampoo a couple times a week and let it kind of sit on their skin. Less well studied, but it does seem to be effective for patients who get recurrent episodes, which again, we don't know the genetics of it as well as we'd like, other than it probably is a little bit more common in Caucasians. So when I was in the military, there's a Hawaiian name. I don't know the Hawaiian language name for it, but it's for tinea versicolor, and it basically means that rash that all the white people get in Hawaiian, right? So there are definitely some racial differences in a lot of these things we've talked about, and that includes actually tinea versicolor. That does seem to affect. Actually, I see it in every ethnicity, but maybe it's a bit more common in Caucasians, so, or at least the Hawaiian language tells us so. So.
I think we need to see that 140 character SIG for having the patient wallow in their sweat.
That's right.
Yeah. And again, it's one of those things, if you don't explain it to the pharmacists, they're like, oh yeah, we know what's up. But when you explain it to the patients, they're a little bit like, oh, that's different. But yeah, that's where I try to tell them the whole mechanism. We're literally trying to get it up. It's like unclogging pores that are full of these yeasts, and you can't really get them in from the inside. Our skin is well designed that we have a lot of one-way valves in our skin. We think of sucking chest wounds with pneumothoraces, but that's kind of every pore in terms of what we call trichomokeratin, and the way our pores are designed, that things from the outside don't get in and things from the inside get out. So take advantage of that. So
I wanted to jump in on one other question with the nummular eczema presentation, which I haven't seen that often. And if you have a 14-year-old who has a annular lesion, let's say, that is very itchy, is the common presentation this patient has a long history of eczema and this is a new variant of their eczema as nummular? Is it a new presentation of suddenly nummular eczema? Because you mentioned that atopic dermatitis can actually be a risk factor for tinea. How does that history of eczema play in, and how does nummular eczema typically present?
Yeah, and that is why this is fun, right? Because it's like, oh man, this is like boss level stuff, because I'm saying that the people who, your mimickers are sort of risk factors for each other. So this definitely overlaps. There's no perfect answer here. But yeah, in general, nummular eczema will be its own thing. We'll see it in teenagers. We can see it in kids. We'll often see it in teenagers. We'll see it in adults who never had any prior history of eczema. You try to beat out of some teenager that, did you have eczema when you were a baby? And they're like, no. And they may not have other signs of atopy. There often will be a family history. It usually still has, a proflagrine basis. That's the gene that underlies a lot of our skin barrier issues that relate to eczema. But yeah, it's often going to be its own thing. That will be their eczema, is nummular eczema. And again, we tend not to have, years and years of nummular eczema, or decades and decades of nummular eczema. We're often able to kind of put it into a little bit more of a long-term remission, Whereas our kids with severe atopic dermatitis, where we're using, biologics, new medications and things like that, because we have to, even though nummular eczema can be severe, it can be very symptomatic and very itchy. It tends to be something we can actually fix, which is nice. So
maybe one other final question we related to. When I think of the mimickers, I often kind of think of these treatment-resistant tinea where, if you're using the wrong treatment, it might not be tinea. That's when I start thinking about the mimickers sometimes. But for people with treatment-resistant tinea, is there ever tinea corporis that you're treating with an oral antifungal, or is it typically if a topical antifungal is not working for tinea corporis, that's when you really should start thinking about these mimickers we've discussed?
No, it really does go both ways, especially when you pull up, the concept of fomites, close contact carriers, a beloved pet that, they keep getting reinfected from. And then, compliance issues, taking the medicine, again, we're all in the same business. Too many parents will trust their 11-year-old to do it all. Let's do pulse therapy, Timmy. So I want you to take this 1 day a week for the first week of every month. And then we're going to pause it for 3 weeks. And yeah, you haven't cleaned your room in 6 months, but I'm going to trust you to do that. So again, this is what we do, and that's okay. Kids are awesome. Sometimes their parents are all right too. So all of those variables can come into play where, again, you question whether the diagnosis is accurate. The diagnosis may be absolutely accurate, and then you could have a susceptibility issue with it. You may not have a high enough dose. Yeah, it's uncommon to have an immunodeficiency present with resistant tinea, but it certainly is possible that would be an uncommon presentation. But we'll see that more often in adults. Sometimes adults with gammopathies, with IgG subclass deficiencies, can sometimes have kind of holes in their immune system that leads to more stubborn infections. But again, we're kind of really getting into corner cases at that point, and that might be the scenario where again, the better the pediatric dermatologist, the less biopsies you do. But, and in fact, if I biopsy something that comes back as tinea corporis, I'm usually like, oh, I'm such an idiot. I can't believe I couldn't figure that out. And I needed to biopsy it. It's embarrassing. Absolutely. We do plenty of embarrassing things in our job. But it also may make me think back, well, gosh, I thought it was that. I'd given the medicine. What's going on? Is there some fomite? Is there some factor I'm not thinking about? That's maybe the kind of thing where we say, we're actually going to treat the whole darn family, which is probably a few times a year that we'll do that. So that's actually with species too, where we start to think about, depending on which species, we might think about ones that are a little more fastidious and might require, treatment of close family members.
That makes sense.
Awesome. Wow, this has been such a helpful episode. So many things that I didn't even realize I didn't know about Tinea corporis. So this has been really helpful. I think as we wrap up, Craig, we were hoping you could tell us what are your main take-home points for our listeners today. I know there've been a lot, but any key take-home points you want to share with everyone?
I mean, it's one of those things as we get further into our career. I think differential is. I remember being like a third-year med student, and you want to go in and know what it is, and you're smart, and you get to be the hero to that student, to that patient, and then the attending comes in, and it turns out you're wrong or whatever. But you didn't really care because you had that moment of like, oh, I knew what it was, But as you get further into your career, I mean, differential is everything. I mean, if you don't consider differential, you're by definition having a little anchor bias, and so if you're wrong, you're actually not all that useful to your patient. So differential is what separates us from a Google search. And, to keep us from being replaced by robots, I think differential. And so this whole episode would kind of speak to that, not everything that's circular or scaly is necessarily fungal. Some of the things that actually are can require, some differences in treatment. And so that's something I stress with my med students and residents that, the most obvious thing you still want to just at least mentally keep those. I would say it's maybe more of an issue in dermatology too. I mean, it's a wonderful field. It's great. There's visual diagnosis, but actually we do see sometimes the same 50 diagnoses. And so keeping your neurons exercising by differential is just so important to serve our patients well. That's what they pay us for.
I think it's a good pearl. And it's also very humbling and inspiring to hear a dermatologist say that, because I feel like in my mind, a dermatologist is just going room to room saying, that's versicolor, that's psoriasis, that's nummular eczema. Like, what are these PCPs doing? Let's get these guys out of my clinic. We got to keep going.
So again, I had my time in peds. I would have been happy to be a pediatrician forever. I mean, I loved my time in peds. In fact, if I couldn't see a lot of kids in what I do now, I never would have gone back for my second residency. And again, not to, sound gushy to the audience, but I feel like pediatricians do a great job with dermatology. They think about it, they take it seriously, they read on their conditions. So yeah, the yield of my typical pediatrician referral is excellent. I'm always happy to get referrals out. Obviously I have pediatricians who've rotated with me for, a decade, and in my town of Dayton, Ohio, where I live, I know a lot of the pediatricians who'd spent time with me when they were residents, and it's great. I'm always happy to see the patients, and hopefully that's how your specialists feel. And obviously things can have good days, bad days. You may have seen them on a very bad day. I might see them on a very good day, but I try to always remember that there's a whole bunch of stuff I don't know how to treat anymore after 22 years from med school. So we all have to have a little bit of professional respect and courtesy for one another. And so it never is a room to room, gosh, this pediatrician was an idiot. I mean, that's just not how it goes.
Glad to hear.
So if anything,
good to hear.
That's our insecurities of dermatologists just making fun of us behind our back. So it's a very kind note to end on, and inspiring note to end on.
Yeah, I would hope not.
And so this has been really great, very helpful, very useful. Is there anything that we can plug that you think listeners should check out? Anything you want to direct our audience to?
Well, the only thing in a general sense when I'm able to speak in lectures or things I give is just to support, medical research, which is harder in kids, but it's out there. So, I run a clinical trials unit when I'm not seeing patients, and I have no conflicts of interest with my clinical trials unit. We have a lot of our own investigational studies, pull my name on clinicaltrials.gov and do things we do on our own. But we do often partner with pharmaceutical companies. And again, even there, we have no conflicts of interest. We're just happy to have the new shiny toys that's all regulated by the FDA and have access to medications. And so, just wherever you are, if you're listening, there are often clinical trials that may be appropriate for your patients that, help us advance the field. And again, I say this as a guy who doesn't make extra money or get anything as a bonus for bringing more patients in, but it is always, for my clinical trial unit, for instance, our pediatricians referring, kids with psoriasis or kids with atopic dermatitis or alopecia areata or some of the things we have some of the new investigational medications for. It's always great when they, trust us enough to consider letting their patients become one of our subjects. And obviously we watch over our subjects closely. So just in a broad sense, considering how clinical research can help your patients, the patient in your room, but also all of our patients, is just something I guess I would plug for given the opportunity.
Love it. Amazing. We love pro research guests. This has been wonderful. Thank you so much for your time. What a great in-depth view of tinea, a very common topic that pediatricians will be grateful to hear about. We really appreciate you, and thank you for joining us on the Cribsiders.
Absolutely. Thanks for having me. Really appreciate it.
This has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts or your favorite podcast player. You can email us at thecribsiders@gmail.com, and we'll get back to you within 1 to 6 weeks. A special thanks to our producers for this episode, Sydney Engel, our showrunner, Dr. Sam Mazer, our wonderful social media team on Twitter, Instagram, and Facebook. Thank you for joining us. I've been Justin Lee Burke.
This has been Sydney Engel.
And this has been Chris the Chew Man Chew. Just kidding. This is Dr. Hain. Thank you and good night.
See y'all.
Hey, you've already listened to the entire episode. Now claim CME credit. Continuing education credit is provided by VCU Healthcare Continuing Education. VCU is accredited to provide continuing education to the entire healthcare team. Check it out at cribsiders.vcuhealth.org for more information and to claim your credit after listening to this episode.